This is the Mechanical Care Forum, and it's season 14. This season, we're capitalizing on the natural happenings of the day. We're chewing the fat on things related to mechanical assessment and patient treatment in the musculoskeletal therapy space with special guests on the ride home. Today, we're joined by Scott Herbowy, discussing him teaching MDT, sharing a couple of patient cases, and tackling the tall order of becoming the go-to clinician for MSK problems. All this on the ride home. Today on MCF. Hey everyone, welcome back to the podcast for season 14. There have been several occasions in my career where I've had the opportunity to spend some time with some very talented and impressive clinicians. I'm referring to those times where I've sat down with a colleague or at the end of a patient encounter and discussed the situation. I've had a chance to travel with some pretty amazing mechanically trained therapists as well on one of our humanitarian efforts, specifically in Peru, and chat about a patient we saw that day. Or I've connected on the phone with a faculty member who had a memorable patient response in their physical exam that day. Some of these moments have been where I've drawn a clinical pearl or two, which has, in a small way, added to what has and continues to make me into the clinician I am today. So this season, I'm catching up with my guests after they've had a typical day in the clinic or in their work, or we're just using the natural course of the day to be the content we draw from, to take something small away and use as further knowledge or inspiration or motivation, or to just put things back into perspective on the ride home. Don't worry, we'll keep our eyes on the road and our hands on the wheel and just have a discussion. So buckle up and tag along with us. This episode is brought to you by Atlas Health. Atlas Health is a web-based exercise and education delivery system, and it's tailor-made for those of us who use specific in-range repeated movements. Are you still drawing stick figures or using photocopies of a still photo or the closest thing you can find on Google for your patient's home program? Are some of your patients coming back doing them wrong or doing something completely different? If you do, you can appreciate how, if more of your patients were doing them right the first time, they'd likely be doing better. Atlas Health is the future of patient guidance between sessions. It's a digital platform with meticulously precise animation, education, and clinician modifiable instruction. In short, it's a better way to deliver exercise and education. Look like the professional you're trying to portray and improve the impression you give your patients. Reduce the lost time when patients get it wrong and enhance the delivery of your care with Atlas Health. Visit atlashealthx.com to see a demo. And just for MCF listeners, use the code ATLASMCF25 for immediate access and a free trial for 25 patients. Go to atlashealthx.com/MCF and get started today. This episode is also brought to you by Therafa. Therafa is a front-end patient intake digital platform to obtain a great portion of the medical history and pertinent symptom history for your patient. Think of it as a way to polish up your intake process with your patients. Capture the relevant information like the history of present illness, symptom presentation and variation, social history, a review of systems, and the pain assessment. It's like having a digital assistant to help you get all the important information to set you up for a more efficient initial evaluation. And it creates a perception of professionalism for your patients when they need every reason to quickly develop trust in you. In my opinion, after using Therafa for several months, it's ideal for the busy clinic where time is of the essence. Right now, Sinju, the CEO and founder of Therafa, has a super generous deal only for MCF listeners. You get 2 months, full access, totally free. Just go to therafa.com/join/MCF. All right, let's get with it today. Scott Herbowy. He's a PT, a diplomaed clinician in MDT, an MDT faculty with the McKinsey Institute USA, a previous diploma program clinical placement instructor from Austin, Texas, USA. Come along with us on the ride home. So excited to continue on this theme of On My Ride Home. We want to welcome to the podcast, this episode, and this season 14, Mr. Scott Herbowy. Scott, thanks for taking time out of the end of a course day and joining us to talk a little bit.
Yeah, it's my pleasure, Jason. It's always an honor to spend time with you and, and spread information to people regarding MDT. And I think I said this on the last bit I did with you. I'm a fortunate guy that after doing this for an extended period of time, I still like doing it. I still like getting up in the morning, whether it's teaching a class for the day, as I did today, or going to the clinic and seeing patients.
Yeah, yeah, and it's awesome that we have a career where we're excited about what we do. Tell me, was this a typical course for you today, or was it quite an unusual, or was it pretty standard?
No, I don't think there was anything terribly unusual, but as one of the longer time instructors, senior instructor, I teach a lot of part C's and D's.
Hmm.
So I don't get the opportunity to do many A's and B's. And people will ask me, what's your favorite course? And I think part C is a particularly interesting course because that's the moment for a lot of people that retrospectively say, hey, that's when things really started to come together for me. Plus now it's the introduction to extremities, which is so exciting. So part C's has always been, I'm like, I really, not that I dislike any other course, but part C's are always such a fun course. But if I had to say what course is probably your least favorite, not that it's a bad thing, would be probably part B. And I think there was evidence of that today in that it typically starts like this. The beginning parts of part B is almost a little bit of a rehash. Well, it is. It's a rehash of part A with the principles, definition of posture, dysfunction, derangement. And, they've kind of heard it. Maybe they haven't absorbed it, but it's necessary background. And I think the morning started out a little bit slow. We were getting through those things, but then as you get later into the day and you start to do more practical things like, okay, this is how you do an exam. This is the things you look for. It starts to pick up. And then as always, the clincher is patience. It's just, and you can see almost the entirety of the room change. And by the end of the day, people are excited. And today, we didn't see the first patient until 3:30, so it was a long day before that. And then we had a 3:30 and a 4:15 patient. And as usual, the patients were, as Mac always said, you learn from the patients, and the patients are so special. And they got a bonus today because the patient they brought in that was cervical spine turned out to be a shoulder derangement.
Oh,
So
wow.
they haven't seen anything like that. So I went through the examination and then got the opportunity to speak to them a little bit about extremities. And I typically on A and B do try to examine an extremity, but it typically pulls somebody from the crowd just to
Yeah.
give them that little bit of taste so they don't walk away, thinking, well, MDT is only for spine and you really can't use it for extremities when in fact some of the best work, in my opinion, that we do is with extremities.
Yeah. 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 Well, interesting. We'll talk more about the patients here in a little while. Tell me this, your typical work day to and from work. Tell me about that commute that you got, that long commute.
Yeah, I tell my commute is either 1 minute or 3 minutes, depending on whether I hit the one traffic light in between my home and the clinic. So it's a pretty. I know you said, well, we talk about what you do during your commute because some people listen to tapes or do whatever. I don't even have a chance to get the car either cool or warm by
Yeah.
the time I get where I'm going. So I'm actually really thankful for that, honestly.
Yeah. So
So
you prefer that. Some people like the downtime to kind of disengage from work so that they're ready to do the family thing or just on to the next thing once they get home, or the same thing on the way to work, kind of get in a mode ready to
right,
work. Have you
right.
had times in the past where you had a long commute?
Yeah, no, I've always tried to find residence close to where I work. So I'm too impatient just to get a long commute. And I think that's why I like MDT so much, that things happen quickly. Uh,
Uh-huh.
when I did a little bit of neuro right out of school, and I just became so frustrated because it was just things didn't really happen. And then and get into MDT where things happen like magic. And you're just, wow, this is good. This is for me. I like
Yeah.
this. Yeah,
Yeah,
yeah, yeah.
absolutely. So paint a picture of the course today, just in terms of students. Were they all younger? Did you have quite a range of ages?
Well, yeah, I think it's certainly they're all younger than me. Although no, not one. I should say actually James McGavin, who actually got his diploma before I did. He's a bit older than me. He's still employed at this clinic, and he spent the day inside the class helping out a little bit. So I can't say all of them, but evidence of how things change is. you make reference to Williams flexion exercises, and the majority of people don't know what you're talking about. No different than if you make a reference to Seinfeld. They don't know what Seinfeld is. So
Right.
over time you learn, okay, wait a minute, you can't use those references. And it's like talking about the Beatles. They sort of have heard something, but they have no idea, right? So it's a mix. And we had a couple people who had already done part C, because you can go from A to C and then backtrack to B. The majority had been A to B. So this is their continuation of spine without extremities, but again, did get that added bonus in there today. So I think that's probably a typical mix where the majority go A to B, and just a few will go A to C and skip. And of course, I think they had a better, they just had more experience. So the two people that were in there, some of their questions were a little bit more advanced mechanical thinking than you might expect on a Part B.
Gotcha. Gotcha. Scott, like you mentioned, you've done this for a long time. What's the material like now compared to when you first started? How much has it changed? You hear from some outsiders that consider MDT and they think, well, I've even heard it referred to as pathoanatomical, and that it's kind of, it is what it is. It hasn't really evolved much. Tell me about your thoughts about that.
Well, I think, the principles are the principles, self-treatment and range loading, a patient-centered focus with a de-emphasis almost on pathoanatomy and talking about those things. Certainly there's been some changes in terminology, changes in definitions, and I think generally they've been favorable over the years, that it puts it in a light. And we've got some changes coming up very soon, some additional changes coming up. It's almost finalized. It's going to be presented, and I'm part of a group of people that have been working on it for probably about a year and a half now. We've had this garbage can term other, just not well defined, with a few almost seemingly random examples. And we've spent a lot of time cleaning that up and being more definitive about that, so that it's not going to be just thought of as, oh, this garbage can. So that's going to be coming. And I think that's an exciting change for people. It recognizes some of the things that are out there, where people say, well, you guys are just, focused on this and derangement, and that's all you do. But it's not. And it always has been really, I think, a comprehensive system, even when Mac presented it, but he may not have consciously recognized what he was doing with patients as far as addressing fear avoidance and things like that. But in essence, he was. He was doing that. He was decatastrophizing things. He was getting people to participate and de-escalate fear that's so common in people with spinal pain and a lot of musculoskeletal things, where they're told, you're degenerating, you have this, you have this, you have this. So I think Mac did those things, I don't want to say inadvertently, but maybe not consciously, and now they've been more well-defined and specifically addressed. So I think that speaks to the strength of the system, in that it can evolve and bring those things, but the foundational principles don't change. They're really pretty much the same.
Hmm. Yep. There's a lack of literature in general in the cervical spine compared to the lumbar spine. Just a lot more work's been done. How does
Yep.
that influence or affect your teaching, Part B, like versus Part A?
Well, I think you acknowledge it and you say, and it's not to make an excuse. You just say, hey, there's this level of evidence in the lumbar spine, and honestly, we don't have that in the cervical spine. And it's not to say that it might not be true. It's just that nobody has proven it. It's like telling people, and a lot of people are I think, maybe surprised by this when you say there's no evidence that improved motion leads to good outcomes in the spine. There's no evidence that improved strength leads to good outcomes. Now, that doesn't mean that that's not true. It's just that nobody has proven it yet. So I think acknowledging that is a strength of the system. Interestingly, there's a gentleman on the course from France, and we were talking at the lunch break, and he was very complimentary of the French branch and the French instructors in particular, because he said they really are very humble. They're willing to acknowledge some of the areas of MDT that we might not be the strongest in or we don't have evidence for, that they're willing to say, look, this isn't the only way to skin the cat. And he said a lot of experience with other approaches is primarily in the university, where one quote unquote guru would come in and say, this is what I do. This is how you have to do it. And the guy that was before me, he doesn't know what he's talking about, and ignore what he was saying. And, and Robin was like that. Robin never spoke bad of anybody. And so that was an interesting conversation that I had with him. And I said, I think that's kind of pervasive throughout the faculty. And it comes from Robin, that we're willing to say, look, this is how we do it. It may not be right. And Robin changed over the years. Initially, he recommended post-surgical, everybody do dural tension stretching to avoid adherence. And then when evidence came out that that doesn't really happen, he said, okay, we've got to stop teaching that because it's not true.
Yeah. 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 That's a great illustration of it. So let's go back to just for a second. You touched on other things that are coming out and evolving, and I have to be honest, just having gone through the diploma program last year, when I went through my cert process, A, B, C, D, way back, it was 06, 05, 06, a long time ago.
Yeah.
It was just derangement, dysfunction, postural other. And it wasn't fleshed out as much, at least so I don't recall it being. And now, that was an area where with Chris and Kim there in Austin, I had to really work a little bit on subgrouping within that. So if you think about a recovering trauma or an inflammatory arthropathy or a soft tissue disease, how does MDT handle those differently? How is it maybe similar to just finding impairments or deficits and working on those?
You mean differently than how we might handle a derangement, or differently than how other people approach them?
Different than maybe other people. Yeah.
Yeah, well, it's hard to speak. People ask me, well, how is that different? I'm like, well, I'm not an expert in what other people do, So
Yeah.
it's hard to say how people might approach those. What I can say is I think we approach them with the same way we approach anything else. It's patient-centered. It's a big chunk of it is education. It's working with the patient to try to develop a program that might have a positive effect for them, but also being realistic with the patient, saying, this may not help. We don't understand, like with a frozen shoulder, why do some frozen shoulders respond quite nicely? And we treat frozen shoulders with a dysfunction model, and some don't respond at all. And we don't really know the answer as to why. So, I think one of the strengths is, not only when we're teaching, we acknowledge some of our limitations, but at least I personally, and I think most people do who practice MDT, can acknowledge it to a patient, versus so many patients relate the stories as, yeah, they've been to 10 people and all 10 said they were going to help them and none of them helped them. And I think that, that again, that's a real strength of the system.
Yeah. Spent some time around some clinicians who don't use MDT, and it was almost just something about a person goes through, in my opinion, through MDT and begins to kind of understand how to interpret what the patient is saying to us, just on their own kind of layperson description of their symptoms and where it is and when they have it and what happens as they continue or don't continue with something. That just brings on a clinical reasoning that I did not have before going through that, whether it's an inflammatory arthropathy or recovering trauma or anything. So I don't know. To me, it's almost like it just, once you understand how to interpret the history and the physical exam in order to classify within derangement, dysfunction, postural, other those three primary syndromes, it just becomes this way of thinking that you apply to all these subgroups within other. I don't know if you feel the same.
Yeah, and I think that translates. One of the things that translates to is I'll occasionally see a patient that went someplace else or and had 24 visits and were no better, but they're quite happy. And I'm thinking, how could you keep going and going and you're not improving or changing and you're very happy versus, and I think the juxtaposition to that is we give people an expectation and they look for that expectation, where I don't think I could have a patient 24 visits and not be improved and have them still be happy. because that expectation, and I think whether it's through our words, through our explanations, through just interactions, I think we give the patient that expectation of change because we expect it to change. And if it doesn't change, we're looking around seeing why it doesn't change. And patients are amazingly perceptive. They see that. So then they get that expectation versus, oh, come on in, get on the bicycle, jump on the total gym. Hey, do some of these stretches, do some of these stretches, and you work on that, and I'll have another guy doing the same thing over here. And they're all just kind of doing things. And I don't think that they get that expectation or the understanding of why are we doing this? When we talk to patients, well, this is what we're doing. This is why we're doing it. And it may seem like it's a bit of pressure on an MDT clinician. Hey, you got to, but I think that's okay because I say it all the time. It's okay to say to a patient, I can't help you, because there is that segment out there that you can't help. And I think I said at the course today early on, I said, anybody who tells you they get 95% outcomes is not really being honest because a Tibetan monk couldn't get 95% outcomes in spines. So, who are we to say that we can do that? So, I think because we're addressing it with the questions we ask, overall how you are versus how you doing today, and trying to get specific information, the patients perceive that and hook into that. So I think they really do have a different expectation seeing an MDT trained clinician than they do when they go most other places.
Yeah, it's an interesting thought. Yeah. Yeah, very good. Let me make a quick break here just to mention case conversations. And Scott, you've been helpful with this. That's our virtual mentoring resource where we bring in veteran clinicians to share actual patient cases. We've been doing it for several years now. We got a lengthy list of cases from headache cases with Audrey Long to mechanically unresponsive radicular syndrome from Hank Templeman, and several cases with you, Scott, including a couple recent ones here where the patient had no pain, but loss of ability to reach overhead, and yet needed two quite different strategies and management strategies to resolve. So if you're out there listening and you have an interest in having exposure to people like Scott and others, check out Case Conversations. That's at mechanicalcareforum.com. Scott, clinicians, the younger students, how were they 20 years ago? How are they now? Do you feel like they come with greater expectations, that they're more questioning or challenging to the ideas, or more accepting? Are they more informed? Or they feel like they are harder to bring along, or do you not necessarily see any changes?
I might not be the guy to ask. I don't really see that much difference, and I think that uh, interestingly, when talking to the gentleman from France today, he said, the problem with PT programs in France is the programs were designed by a bunch of old guys from the 80s. I started laughing. I thought, well, yeah, that's when I got my PT degree. And I think that as far as I can tell, that I've had the opportunity in the past couple of years to start working with some very recent grads. And my take is that their training is still quite similar to what it always has been. And as much as people like to bang the evidence-based drum, they're still, teaching things that fly in the face of the evidence that's out there. And I've had conversations in the past with some university instructors and said, one university instructor, I remember when Mark Miller and I were working together, and she came to see Mark and had a very good result in just a couple of visits. And Mark asked her, he said, why isn't this the primary focus with your PT students? And she made a very good point. She said, the problem is if we focus on this, when these kids go out on clinicals and they end up in a clinic that isn't either a believer in MDT or doesn't have MDT trained clinicians, she says they get killed. So we have to literally teach them a little bit of everything so that they get out there, they can kind of fit into the clinical situation that they find themselves in near the end of their training.
Yeah.
And she acknowledged, she said, I think this is probably the way to go for orthopedic problems, but it's virtually impossible for us to make that a focus for that very reason. And then that did kind of make sense to me. And, in Robin's opinion of it, he had a pretty, I would say, negative opinion about MDT being taught at university levels simply because he said, look, you can't learn this stuff in an afternoon. And that's often what happens. Oh, we're going to have our MDT lecturer come in, this Friday from 1 to 5 o'clock. And that's the exposure they get.
Yeah.
And it's obviously incomplete.
Mm, yeah. So you had a patient at this afternoon, 3:30 and 4:15. Just give us a little glimpse of the patient at 3:30.
Yeah. The first patient was a mature woman who works as a housekeeper and was referred for quote unquote her neck, but very local anterior shoulder pain, no neck pain, no scapular pain, no referred pain, no paresthesias, no reporting of symptom being affected by either sitting, bending, twisting, which are some of the factors that are pointed out in the expo study, and clearly described her primary complaint was, I have trouble reaching behind me, getting dressed, and I can't sleep on it, which to me kind of screams shoulder. So we did screen her neck, and of the 5 factors that would indicate spine origin, she had 0. So movement loss assessment in the cervical spine, nothing. So then we were able to go on and look at her shoulder, and by her own admission, her functional internal rotation reaching behind her back, she said at the end of about 30-minute session, she said that had improved by about 50%. She had limitation in elevation with end range overpressure that she was not even aware of, that had completely cleared. So she was quite happy. And she was quite interesting because I asked her if she had had any other treatment. And she said, well, I did a bunch of, I had these bands and I was pulling on them and I worked on that. And I said, oh, you got that at therapy? And she said, no, I just did that on my own. I bought some bands and I figured it would be good. And self-deprecating, she said, but I don't think it worked because I wasn't consistent with it. So,
Okay. She's awesome.
but she was trying to help herself.
Mhm.
So she was an easy sell as far as, okay, this is what you need to do. She recognizes the changes and said, I think I need to be more consistent. I said, well, instead of doing 3 or 4 different exercises, now you only have to do one. So she was right on board. And again, atypical to get an outside patient with an extremity on a part A or B course, but I never think that's a bad thing.
Scott, when you have somebody like that, obviously it's a lot easier if they're really motivated. They're looking for things, they're trying things on their own. So it almost sets them up to really do well because we're asking them, of course, to integrate these into their day multiple times. What if you have that patient who's just not motivated? We know that spectrum of pre-contemplative, contemplative action. You have that person who's not. What's a strategy that you have seen is helpful?
And it's interesting you say that because our next patient was
Okay.
an older gentleman, and I saw he had been referred to the clinic here where I was teaching, and he literally had walked in with his prescription to the clinic, which was right next door to the auditorium, and they said, "Oh, good, come with us." And they brought him right over, and he came in and I introduced myself, and I said, "Well," and I always give people background and say, "Hey, just to let you know what we're going to do, we're going to bring you up front, we're going to ask you some questions, we're going to move you around and see if we can figure out something for you." And as soon as I said that, he said, "Where am I going to be?" I said, "Up there." And he says, "I don't want to go up there." It was, I don't want to be sitting in front of these people. And he said, "Nobody told me about that." And I said, "Oh, okay. I don't want to force you, to do anything." And the therapist that was going to see him, she said, "Well, he's just going to do the same thing I was going to do. It's just there are some people sitting there and they're all doctors and therapists and chiropractors." So, and he looked and he looked and he said, "Oh, okay." And he came up and cervical radiculopathy for 2 years. And his primary complaint was problems with sleep. And also during the movement loss assessment, he had a lot of pain with rotation. He had a lot of trouble doing retraction, and retraction was producing neck and scapular pain. It wasn't sending anything down the arm, but it was just produced, not worse. And I could kind of sense he was like, okay, this is hurting, but so what? Blah, blah, blah. And I said, well, let's check your turn again. And he turned and he said, oh, I said, same or different? He said, that's the same. I said, okay. And so we did a little bit more, and we found that by just changing the angle in his thoracic spine, he could get a much better retraction movement and not experience really shoulder pain, more local to the neck, which I talked to him about, showed him that. And he said, yeah, I feel it, but it's much milder than that pain I was getting out here. I said, well, let's check your turn again. And he said, man, you're killing me. And he was serious. He said, man, you're killing me. I said, okay, I got you. But I just want to check one movement. And he turned, he said, well, that's the same. I said, okay, well, let's do a little more. Let's work on this and let's work on, it's wonderful for you. You have a way to tell if you're doing the exercise correctly, because if you do it and then shoots out to the shoulder, you've got to change this and get it to where it doesn't shoot out to the shoulder. And he said, okay. And he figured it out. He figured it out and he did a bunch. He did a bunch. I said, okay, let's check that turning. And he kind of looked at me and then he turned and he turned and he turned and he could see his eyes get about this big. And he turned back and he looked at everybody and he said, I can't believe that. And I think that's what you got to do with somebody like that. It's that demonstrate cause and effect. And because the symptom was intermittent, produce not worse or up here versus arm, even though I explained it, how much does that mean to a guy like that? Versus you are killing me going to, boy, that doesn't hurt anymore. And you could almost just see him light up. And he even acknowledged, we did a little bit more, talked about his home program. And then he said to everybody, he said, I didn't want to come up here. I was afraid of what was going to happen. I wasn't sure that was going to happen. He said, and now, and it's exactly where he said, now I'm damn glad I did come up here. So you can see that change. And I didn't bang away with 1,000 of these, making his hurt for no reason. I was just looking for that one little change that he would. And I said to the folks, I said, when he said, you're killing me, I went, aha. If we can change that, that's going to mean something to this guy. I couldn't change his sleep pattern, obviously, which was his primary complaint. But boy, you're killing me. I'm like, okay, we got something now. And if we can change that's going to mean something to this guy. So, you always have to look at, a lot of clinicians, I think, look for changes that mean something to them, better strength, better motion. But I'm always looking for what's the most meaningful thing for the patient, because that's ultimately how you get them, to buy in. The flip side of that is, Jason, some people are never going to buy in.
Yeah.
And we know that. It doesn't mean you don't try, but some people just don't buy in. And, at a certain point, your hands are tied if they don't buy in.
We've all had those patients that you see the light bulb click, but in some patients, based on their history, based on even their presentation, that this is derangement. Or it's, I guess in this case that I'm giving you, it would be mechanically inconclusive, but it has derangement behaviors to it or historical remarks from the patient, yet you can't find that directional preference on day one. And so you've got to regress the force a bit or whatever to try to. So in that case, if you just kept have it, or maybe it started to go down in the arm, and you needed to dampen how much movement was happening at the cervical spine, maybe just move the thoracic spine, but it might take a couple of days before then you could reintroduce cervical motion and cause centralization. So in those cases, when you don't get a good aha moment, how do you keep that patient engaged so that they're kind of hang with it, knowing that, boy, if we could just soften this up a little bit, I bet we could move and get you beyond and centralize.
Yeah, and if I could back up for a minute, the other thing that was interesting about this guy when I started, and I said to him, like I say to many patients, if we can find the right movement, even though you've had this for 2 years, you can get better pretty quickly. And he looked at me and he said, "What's quick mean?" And I said, "A week or two." And he was like, You can see he wasn't really buying in, and I acknowledge that. You see patients who've had it for 10 years, and you say, "Hey, you can get better quick," and they're like, "Yeah, how does that work?" I've seen all these other people and all that. So when that changed, I think there was also that connection. Is like, wait a minute, this really can change quickly, and help them buy in. I think in the situation you're describing, where you can't find the aha movement. I explained to patients what I'm doing. I said, and I've had patients say to me, "It looks like you're experimenting." And I go, "Yeah, I am. I am looking for that thing that is going to be, and right now I can't find it. So we have to test this. We have to explore, and we have a number of things. We're not throwing in the towel with the first thing that doesn't work. We've got a number of things that we can look at, and we will always look at the things that typically are most prevalently beneficial. But if it doesn't, we go down the line of looking for other things. So we're persistent in our exploration. And unfortunately, there are times when I have to say to the patient, "Look, I just can't find it. I wish I could." And I'm sure you've had the experience too. It's always that patient that you really want to help. You can see they're either distressed by what's going on, or it's really interfering with their life. They're good self, they're participatory, they're motivated, they've got all the right ingredients, and you just can't bake the cake. And you're like, darn, I wish I could help it. Where I see some people that, gosh, this is a simple thing, and you just won't participate. Which is frustrating. But I think it's more frustrating when you have that person that is so obviously motivated that you can't find the magic button, so to speak.
Yeah. 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 So, such a challenge in some patients, and in some, you're right, finding that good thing that's meaningful to the patient and letting the patient kind of see it for themselves. And it almost becomes their idea. Oh, yeah, I think I'll do some of this throughout the day then.
Right, right. Again, it's back to that demonstrate cause and effect, and it's
Mhm.
cause and effect on what's important for the patient.
Mhm.
So we got that aha moment with him with turning, but ultimately he's going to need to come back and say, "My sleep is better." And, great, this is better. But that wasn't one of his primary complaints. It only came up as we were examining him that he remarked about that. But Robin used to say, we'd see a patient with Robin, and Robin would say, "What's the essence of this person's problem?" And the essence of this guy's problem is he can't sleep. He's waking up 3 or 4 times a night with, he says, terrible pain shooting down his arm. And ultimately, we have to change that in order to continue with that aha moment.
Scott, do you address the thickness of the pillow and a cervical roll day one for a guy like that who that's his primary issue? Or when you find a reductive load like that, do you just let it to see if is that enough that
And I think I mentioned in class today, I'm not, it's so difficult to influence sleep position. And I've always been of the mind, if you fix the problem, then the nighttime problem goes away. And this guy was interesting because I had him with a lumbar roll. And at the end of the session, I said, "Now, part of your program is, this is helping you. This is going to make you worse. You've got to sit with this cushion every time you sit." And he looked at me and he said, "Every time I sit?" And I said, "Yeah." I said, "No, you have this problem at night." And he says, "Yeah." I said, "If you had a sprained ankle and you went running and got in the bed and your ankle ached, would you be surprised?" He said, "Well, no." And I said, "Well, what'd you do last night before you went to bed?" He said, "Well, I watched the game." I said, "You watched the basketball game?" He said, "Yeah." I said, "Where were you sitting?" He said, "On the sofa." I said, "You mean like this?" I said, "Does that remind you of the sprained ankle going for a run?" And he kind of looked at me, and I said, "Does that make sense to you?" And he says, "Yeah, I think that makes a lot of sense."
yeah.
So, um, I think influencing, or you have a better chance, obviously, of influencing what happens before they get into bed,
Mhm.
more so than necessarily what happens once they're in bed.
Mhm.
So I think that you try to address that. Um, People with sleep difficulties always have them do, if you find directional preference. I had a lady in the clinic this past week with a hip derangement, and she said, "During the day I'm great, but it still wakes me up at night." I said, "Well, you need to do the exercise, right before you go to sleep." And she said, "I never thought of that." And I said, "Well, do you do the exercise?" She said, "Well, no, I get lazy and I taper off probably after dinner time, and I don't do much of it in the evening." And, she said, maybe I should. Like, yeah, maybe you should. So I'm more of the mind of let's see if we can, skin the cat that way then versus, well, here you just need to sleep on your side and not sleep on your stomach or, whatever it is.
Yeah. Yep. You mentioned real briefly at the start of that story, the account of that patient, that he didn't necessarily have those indicators. And I don't know if everybody caught that, but will you just kind of expound upon that a little bit, Scott? We know that that paper shows there's five indicators
Yeah,
that
it was,
predict
it was
good
the
health.
first patient, the woman, the
Yeah, I'm
housekeeper.
sorry. Yeah.
Yeah,
Sorry.
yeah.
Yes. Yes.
The indicators of increasing likelihood of spinal origin. Do the patient's symptoms change with change of sitting position? And
Mhm.
that's the strongest. Does the patient historically report pain with bending, twisting, or turning of the spine? Does the patient have paresthesia in the limb? Is there movement loss in the spine? Is there no movement loss in the extremity? There's two ways to look at that. She had movement loss in the extremity and no loss in the spine,
Yeah.
which pushes it toward extremity. No paresthesia, no change with change of sitting posture. And I asked her about bending or turning of her head, or influence of her moving her neck, and she said, "No, it's all arm. It's got nothing to do with moving my neck."
Yeah. And so that would, in normal or according to the study, would reduce the likelihood of there being any extremity pain of spinal source.
Yes, that really put a kibosh on spine origin for her extremity pain. Now, in the guidelines, and if people aren't aware, we've put out some, and I don't want to say guidelines, some recommendations as far as what does it mean to clear the spine. And even with no factors, we still do a movement loss assessment in the spine. And I don't necessarily, I think the guideline or recommendations say do a set of the exercise. I typically have the patient do a couple of repetitions and add some overpressure to it. And if there's nothing there, the likelihood that the spinal involvement is, I think you move on. And I don't think you could say spinal involvement would be impossible or zero. There's always that possibility, but as long as you know in the back of your mind that there's that possibility, if it doesn't sort out when you go to the extremity, you can always go back to the spine. And the other thing I try to talk to people about is there's a lot of times there's not an obvious right answer. I say that's not a fork in the road, it's a pitchfork. And you don't know which of those tines is the one that ultimately is what that patient needs. That's not a problem as long as you know that you've got those four options and explore them methodically, and you'll come to the one that's best for the patient. And don't be worried about, oh, I don't know exactly which one that I should do first. Just know that you have those as options available to you.
Yep. Yep. No, thanks for that clarification. One more quick, brief interruption here. Within our research resource, Inside the Science, that's our scientific research summary and discussion where we bring in authors to talk about their papers. We've had over 8 seasons. We've spotlighted papers on just a gob of things: ortho special tests, the effects on patients and their outcomes from diagnostic labels, the effect of outcomes from booster sessions, that is, those touch points between appointments, observations like scapular dyskinesis and whether they're found more commonly or the same amount or less in subjects with shoulder pain versus those without, and on, just paper after paper with good authors who authored quite a few scientific studies. So if you're having trouble keeping up with the literature and you need a little help, check out Inside the Science. You can find that at Mechanical Care Forum as well. Scott, talk to us a little bit about the holy grail of influencing our society, of instead of being and having the this societal belief that, well, if I have a problem I need to go see a doctor or a specialist or whatever to get an MRI and go that route first versus seeing some, it's something that we're pretty confident that maybe we shouldn't go to the clinician who does the most invasive thing, the most irreversible thing, but start with someone who just finds what can the patient do for themselves, which seems a lot more reasonable, plausible to us at least. But it sure doesn't seem like in your general population out there that we're maybe making much headway in changing that attitude. What are your thoughts about that?
Yeah, I agree with you. It's so hard to make headway because the system is designed for that. Unfortunately, the system there's rewards in catastrophizing problems rather than taking the simplest route. And I think I so often refer back to Robin and in Robin's thoughts, he said, we need to make ourselves indispensable. We need to prove to people that we are indispensable in the first option and not we'll give this a try before we go out and do something or have it skipped over completely. And, that's a tough road to travel. And it certainly takes time. We didn't get direct access in Texas until I believe January of 2001. And the clinic I'm at, private practice, probably, I think the last time it was looked at, between 30 and 40% of our patients now are direct access. And most of them come word of mouth. I came because you guys helped my sister. My neighbor said you need to come. And, over the years, I've heard people say, man, this is great. But if I treated like this, I'd go out of business because we fix people too quickly and we turn over patients quickly. And I think that's really true in the short term. Yeah. But once you prove your value, your worth, and it takes time, and being indispensable, as Robin said, then your business, blossoms. And I'll give kudos to the guys out in the Central Valley, California, who are very MDT oriented. They have 19 clinics in the Central Valley, and they have all their PTs and PTAs take MDT courses. And what they do is very and the growth. I think they've been around for 20 years and 19 clinics. That's amazing. And I think that speaks volumes, not only to their guys' dedication, but to MDT and what happens. Mark and Chad in Florida, Bob Robinson in North Carolina, Yaw in South Florida. And to start with, it is difficult, but once you get that reputation and word gets out, and we need, more people, that are well trained and really promote this and do this for people and get out there and talk to people about it.
Yeah, Dana Green's comment about how we shouldn't be seeing some patients a lot of visits. We should be seeing a lot of patients a few visits. Really comes to mind with
right. I would rather see 10 patients, 5 visits than 5 patients, 10 visits. Yeah. But the only way you can do that is you got to have those people walking through the door. But again, 30 to 40, I think that's I was surprised by it. And in some ways, and I'm certainly not taking all the credit for it because we have other outstanding clinicians in our practice. But I think that's a pretty telling number that within just a few years, soon we'll probably be approaching 50% of our practice of people just coming from other people. They're not being told you need to go here because the doctor says to go here. They haven't seen the doctor.
Yeah. And that sometimes makes the whole process a bit easier if they haven't gone down the route of getting labels and
catastrophize and fear, you're degenerating and you've got this and you've got this and you've got this and you've got this.
Yeah, the spine of an 80-year-old. I love that one. Yeah. Well, listen, I appreciate you, first of all, being willing to take it almost an hour now after a long day of teaching. So we'll let you kind of chill the evening, get a little dinner or something. But Scott, thanks so much for continuing to carry the torch, teaching all these courses. And I always enjoyed courses that I've gone to that you taught. So thanks for taking a little time this evening, talking here on the podcast. We appreciate you coming.
Yeah, it's my pleasure, Jason. And I thank you for what you do. And, I get asked often, you quote this study or talk about this, where can I get that information? And, when people first asked me that question, you weren't doing your things. And I would say, well, you go to the McKinsey website and we have a list of references and the abstracts and some information printed out. So now I've got to be sure to say, hey, you got to check out Jason's site because he's involved in that. So, and I think that's a great service because having evidence for what you do, adds strength. And as the evidence evolves, it continues to support what we do. So I want to thank you for that and encourage people to look at that.
Appreciate that. And there you go with episode 406 with Scott Herbowy. I love how Scott boils it down. Find a change meaningful to the patient more so than one meaningful to us as the clinician. His personal observations when dealing with a patient with disrupted sleep and giving greater effort on influencing what happens during the day versus modifying the nighttime position. And some discussion on screening the spine. Know those 5 indicators associated with extremity pain of spinal source. Thank you, Scott. Don't forget about our sponsors today, Atlas Health, a more precise and professional way to deliver exercise and education to your patients. If you use end range, repeated movements, and sustained positions, and you teach patients to test and retest their motion, and you're still using pictures from Google, hand-drawn stick figures, or even your patient's phone, welcome to the 21st century. Get your first 25 patients free exclusively here at MCF. Go to atlashealthx.com/MCF. Click to sign up and enter your information and the code ATLASMCF25. And our other sponsor, Therafa. If you could use a better way to intake your patients, gather the relevant information before the patient even arrives, and make you more efficient, check out Therafa. Take advantage of his special offer, 2 months totally free. You'll find that special deal at therafa.com/join/MCF. All right. Thanks for coming along with us on our ride home today. Be sure to come back next week and hang out with us for our next guests on the ride home. For more of sharing experience for improved patient care,